morning, colleagues. It's 9:30, so we're just going to start. Just like to remind you all that this meeting is being recorded so that it can be shared in the public domain, just to make you aware of that. So welcome this morning to this IJB. I've got some sort of welcomes I would like to do. First of all, I'd like to welcome Councillor Fiona Colley back. Fiona will be our Vice Chair, and you will all be familiar with Fiona. In terms of Fiona's background, Fiona's got a background in policy and public affairs and working in the third sector. I'd also like to welcome this morning Councillor Stacey Devine. Stacey's an advocate for vulnerable people and has done a lot of work around gender-based activity. So I'd like to welcome Stacey. I would also like to welcome Councillor Anne Hannah, who has extensive experience in welfare rights. And if I understand correctly, Councillor Hannah has also worked in social work, and she worked in social work at the time of sort of health and social care integration. So another fantastic asset to this board. I can see that Gillian Morton has joined us today as well. Gillian is the Interim Nursing Director for NHS Forth Valley. So welcome this morning, Gillian. I would also like to welcome Helen Welsh, who will be shadowing Roger Wrigley, who's the Falkirk Council staff rep this morning. And last but not least, Stephen Kirkwood. Welcome, Stephen. Stephen is the Chief Finance Officer on an interim basis at the moment. So this is Stephen's first meeting today. I believe, Dave, we also have some apologies. We've got apologies from Margot Briggs, Kathy Cowan, Frank Donnelly. However, Morven Mack is attending on behalf of Frank today. And do we have apologies from Suzanne?
Oh, sorry, apologies from Suzanne Thompson.
Okay, thank you very much. That then takes us on to any declarations of interest. And we have none. Okay, if we can then look at the minute of the last integrated joint board meeting held on the 18th of March. That's pages, certainly my pages 3 to 12. If we just look at this for accuracy, so page 1, page 2, page 3, page 4, page 5, and page 6. I've said my minute went from 3 to 12, but it does, sorry. And what is my page 12? So I'm getting myself all confused here. Anything anyone has to say? Are we happy to agree that that is indeed an accurate minute of the last meeting? Fantastic. Okay, in terms of the action log, there are 3 actions there, 3 active actions. So there's IJB 213, which is on the agenda. And then we've got IJB 5. So Patricia, I can see that's not on the agenda. Do you want to give us an update on that?
Yep. Discussions are continuing with the NHS Chief Exec and the Chief Officer. In that regard, there's also been a recent meeting with the local authority chief execs, the chairs and vice chair, the chairs of the IGB and the chairs of the health board. So there's a plan in place, and we can report back at the next meeting on the progress.
Okay, thank you. And then we have IJB 45, which I believe will be included in update in the Chief Officer report. Correct. Fantastic. Okay, that then takes us on nicely to the Chief Officer reports. I'm going to hand over to Patricia.
Thank you, thank you, Chair. Members of the board will see before you the regular Chief Officer report, which provides an overview and an update on some of the activity and key events and some decisions for the board to make. We continue to face quite considerable pressures in the system with increased demand through the hospital, but also from our community, and are working with colleagues across partnership in the third sector to address and mitigate those demands. And you'll see that some of those outlined in section 4.7 of the report. In relation to some of the developments, I draw your attention to section 5.4, and that's in relation to the facility at Thornton Gardens. If you remember, that was a former field facility which the council and the IGB agreed that we would take on to provide respite care initially, and that was a decision at the meeting, the IGB meeting in April 2019. And then in June 2020, there was agreement that we would deploy. There were only 4 beds being used in that unit, and this was previously a supported living facility where there's sort of studio accommodation with a bedroom, a small kitchen, a bathroom, self-contained. So at the meeting in June 2020, the board agreed that we would use some of the beds in the rest of that facility for intermediate care, and that has been working very well. That required a change and a bit of flexibility from the care inspectorate to enable us to be running 2 types of care within the one building. And the care inspectorate were quite keen that we remediated that situation as soon as we could. We've, since April 2022, we've not taken any new intermediate care admissions into Thornton Gardens and have now got that additional capacity for broader respite provision within Thornton Gardens. So you'll see that detailed from section 4. And we've also applied for the new registration of that building. It is a good news story in terms of our provision of respite, but as you know, we have got investment for intermediate care beds within the Falkirk Community Hospital Master Plan. We've also been re-provisioning intermediate care within some of our external care homes, but that is something which we will bring back as part of that community bed-based modelling, really looking at what type of support do we need, what type of beds do we need in our community. At section 5.7, just to draw your attention to the update on the home support and supported living contract, and that's effectively our care at home and supported living, and that's a key tender that we're in the process of developing to go out for our care at home. And we have extended the current contract as agreed at the last IGB meeting. So there's a bit more detail in that process within section 5. Section 5.11, just to draw to your attention that Falkirk has been one of 5 partnerships involved in a pilot training programme with the Coalition of Carers in Scotland and Carers Scotland. And that's been to develop a model of training and support for individuals to become involved in some of the Integration Joint Board and other committees and working groups to ease that interface and to support people to do that effectively. And as you know, as a partnership and a board, we've been really quite proactive in terms of the way we work with third sector communities, carers, and those with experience of care. So I'm delighted to tell you that we've been running that training programme. I participated in a small part of that, and it was really good to hear some of the challenges that people have in performing that role of representation and some of the ways that we can make that easier. And I'm delighted that one of the participants is here today as an observer for the board, and she's most welcome, Gillian. In relation to the rest of the report, you'll see at section 6, we've outlined transformation priorities. This is very much aligned to our remobilisation recovery plan. As a systems leadership team, we've been looking at the number of projects that we have and actually trying to look at how we prioritise our efforts given the range of demands that there are on the system just now, but also on our staff. So you'll see those identified in 6.2 and some detail thereafter. There's an update on the Falkirk Community Hospital Master Plan at section 7, and also a piece about the annual performance report. We're proposing, in line with other IGBs, to seek agreement to delay the publication of that report until September. And my apologies, that is section 8, and then the sub numbers are 9 and 9.1, so my apologies, that's an oversight on our part. So to move to the recommendations of the report, and I haven't touched this, as you'll be aware, since we've been in the emergency status in the NHS, which is now stopped as of May, 1st of May this year, we had an arrangement which we reviewed every board meeting for delegated authority to myself in discussion with the Chief Finance Officer, the Chair and Vice Chair, to take decisions that may be needed between board meetings. So we would have expected now that the emergency situation or the status has changed to discontinue that, but on the cusp of the recess of council and also the continuing demand that we have in the system, I'm proposing in the paper that we continue that for full review at the next meeting in September, just to get us over the summer if there is a need for some strategic or significant financial decision out with the current board cycle. So that's the first recommendation. The second is to agree the publication for the annual performance report. The third one is to delegate, there's a workforce plan that requires an integrated workforce plan that requires submission before the next board meeting, and it's asking for delegated authority to submit that to Scottish Government as a draft subject to agreement at the next board meeting. And also that I submit a partnership response to the current consultation on a health and care strategy for older people. So thank you. I'm happy to take any questions. Thanks.
Thanks, Patricia. Do we have any questions for Patricia? Morgan.
It wasn't a question, it was just a comment. I was really pleased to see in the report the news of the training that was undertaken with the Coalition of Carers and Shared Care. It's going to make a huge difference, and it's going to mean that the impact on carers, that having their voices heard, is going to be greater. It's always been good, and this will improve things even further. So thank you very much for that.
Thank you.
Okay, thank you, Morgan. Councillor Colley.
I suppose my question is around Thornton Gardens, and obviously the change in registration back, I suppose, to its original intention. I suppose that the question is around the flexibility of the care inspectorate were we to experience a period where we might need that again for other types of support in relation to intermediate care.
Thank you.
Yeah. Gail, do you want to come in response to that?
Yes, thank you. Yes, Councillor Colley, just to respond to that. So the Care Inspectorate over the last year has had a different arrangement whereby we can accept people on an interim or intermediate basis into all care homes without requiring a formal change to registration. So they have confirmed that that arrangement will continue through till March 2023. So if required, we can still access it, but we've changed the formal registration in Thornton Gardens in line with just to make it more straightforward from the Care Inspectorate perspective to support a single service user group.
Thank you, Gail. Councillor Crawley, are you satisfied with that answer?
Yes, thank you. That was very helpful.
Thank you. Do we have any other questions for Patricia? I'll give you a second or two because sometimes I'm a bit quick off the mark. Moving on. No, I don't see any hands. Do you want to go through your recommendations again? Or are we just happy to ask them to approve them?
Yeah.
Okay, colleagues, are we happy to approve the recommendations as set out in Patricia's paper today?
Agreed.
Thank you very much.
Thank you.
Thank you, colleagues. Okay, if I can then move us on to item 6 on the agenda, which is the 2021-22 draft financial outturn, and I'm going to hand over to Stephen for this one.
Thank you and good morning, everyone. So agenda item 6 is the 2021-22 draft financial outturn. The report provides an overview of the draft financial outturn for 2021-22. That's from the 1st of April 2021 through to the 31st of March 2022. Position is draft, being subject to review by external audit. In terms of the headline figures, there's an underspend of £1.187 million reported against core operational services within the integrated budget, and an overspend of £700,000 is reported against set aside. Closing reserves for 2021-22 are £37.891 million. and that's an increase of 19.891 million compared to the closing reserves in the previous financial year. The movement includes a number of year-end allocations from Scottish Government, most notably additional unanticipated COVID funding. In addition, there's been delays in some planned expenditure against a number of earmarked reserves. The previous report to the board forecast a break-even position for the integrated budget, and the favourable movement reflects improvements in both the community healthcare and social care positions. The set-aside positions broadly the same as before. Table 1 sets out the performance across large hospital services, primary care, social care and community healthcare. The large hospital services overspend of 700,000 will be directly managed by NHS Forth Valley as part of set-aside arrangements, while the integrated budget underspend of 1.187 million will transfer to general reserves. Section 3.4 of the report provides an overview of the main factors contributing to the overall position, analysed across large hospital services, primary care, social care and community healthcare. Section 4 of the report provides details of COVID-related expenditure and funding, and in particular Section 4.2 references the 15.5 million of Scottish Government funding received to date in the financial year. Most of that funding has been transferred to reserves to be used in 2022-23, where no additional COVID funding is expected. Section 5 of the report refers to movement in reserves of 19.891 million, with Table 2 indicating that most of that, 19.316 million, is attributable to late funding allocations, while the remaining 575,000 is attributable to delays in planned expenditure. Appendix 1 of the report provides details of both the movement and the closing balance for each reserve by project. Finally, in Section 6, we have the conclusions, and I would draw your attention to the legal and risk implications on page 36, which highlight the largely non-recurring nature of 2021-22 variances and the emerging risks for 2022-23. Back to the recommendations. The board is asked to note the draft financial outturn position and note the unaudited accounts will be considered at the Audit Committee next Friday on the 17th of June. Thank you.
Okay, thank you very much, Stephen. Do we have any questions for Stephen? Gordon.
Thank you, Chair. Not a question, more a comment on the level of reserves. Last year in the commentary to the account and in the communications material around it, we talked about the kind of unexpected and exceptional nature of having a very large reserve. And this year we're showing actually almost double that amount. So I think, again, while there are very good reasons for that, as Stephen has just outlined, I think we just need to be careful about how we communicate that, because it's a kind of strange message in some ways to be saying, on the one hand, we're under a great deal of pressure and money's going to be tight, but on the other hand, we have 30-something million sitting in reserve. So I think there's just a need for careful communication around that, Chair.
Thank you, Gordon. That makes sense. I don't know if either of you want to come back in on that.
Yeah, I think it's a particular challenge. It's the same challenge that IGBs have. Scottish Government have been clear that they've given us the allocation and there is unlikely to be any more money for COVID. So we need to just bear in mind that should there be any further developments in relation to other strains, etc., that money will be more than called upon. So it's about getting that balance between being able to be proactive and use the money, but also to be reactive. I think fundamentally as well, and we've rehearsed some of this previously, one of the biggest challenges is actually recruitment and getting people into posts. We've got the irony of having investment money, but a lot of it's non-recurring, but also we have challenges and considerable staff vacancies. So there's some real tensions in the system, but it's a point well made, Gordon, and one we're very alert to. Thank you.
Thank you, Patricia. Any other questions or comments? No. Okay then, are you willing to note In terms of the recommendations, both that have been made by Stephen in this paper this morning. Yeah, unless I hear anyone say no, I'm going to take it that you are. Okay. I'm then going to move us on an item to item 7. Excuse me, which is the 2022-23 financial update. And again, I'm going to hand back to Stephen for that one.
Thank you. I'll spend a bit longer on this report if I may. The report provides a high-level summary of the current financial position after the first month of 2022-23. For this period, a net overspend of £53,000 is reported, reflecting ongoing pressures within set-aside and primary care. Several new and emerging risks have been identified, including social care provider sustainability, non-pay inflationary pressures, increased demand for complex care, and ongoing uncertainty regarding COVID-19 funding. The report outlines a number of investment opportunities to support a shift in the balance of care through innovative use of funding to enhance mental health services and support other services by utilising both winter funding and the use of the underspend from Falkirk Community Hospital ward closures due to fire-related health and safety issues. The current budget for 2022-23 stands at £262.512 million, and that comprises £35.5 million for set aside and £227 million for the integrated budget. The budget will increase over coming months due to outstanding funding allocations, including the agreed contract uplift for family health service contractors and the NHS Agenda for Change Pay Award. In the meantime, the directions which we see in Appendix 1 identify the payments to both Falkirk Council and NHS Forth Valley based on the current annual budget. In terms of the year-to-date performance, as I said, there's a net overspend of £53,000 at the end of April. This comprises an overspend of £155,000 against set aside, which is partly offset by an underspend of £103,000 for the integrated budget. And we can see these figures in Table 1 within Section 4.1. Within set aside, there are ongoing workforce pressures within accident emergency and various inpatient specialties, including rehab and specialist mental health services. The main pressure within primary care is currently within prescribing, while break-even is assumed in respect of social care at this point. There are several new and emerging risks at this early stage of the financial year, including social care provider sustainability, non-pay inflationary pressures, particularly around energy prices, fuel prices, and other supply chain issues, and there's increasing demand on complex care, including pressures from transitioning from children to adult services. There is uncertainty in respect of COVID-19 costs, and further clarity is expected from the Scottish Government. In terms of the social care provider sustainability concerns, contractual rates for 2022-23 have been increased to include both pay and non-pay inflationary uplifts. Provider funding also supports full implementation of the Scottish Government Adult Social Care Pay Policy, where staff employed in direct care roles must be paid a minimum of £10.50 per hour. Local providers have welcomed the increase so far, but there are ongoing concerns in relation to the scale of cost of living and inflationary pressures, and this position will be kept under review. In terms of the investment opportunities in the current year, Section 5 of the report lists a number of opportunities, starting off with winter pressures. So, significant recurring funding was announced last year as part of a national funding package to address winter pressures and support longer-term improvement in service capacity. The table in Section 5.2 of the report lists £11.9 million worth of investment funding. Much of this is recurring funding and includes £848,000 for recruitment of additional healthcare support workers, £1.131 million for recruitment of multidisciplinary staffing, £174,000 for staff wellbeing, £579,000 for interim care, 3.517 million to increase capacity in care at home, just over 5 million to implement the adult social care pay policy, and 622,000 for social work workforce capacity. In section 5.3, funding has also been announced for mental health and wellbeing in primary care to include multidisciplinary teams within primary care settings to provide assessment, advice, support, and some level of treatment for mental health, distress, or wellbeing. There is an expectation that mental health workforce in primary care settings will increase by 1,000 additional staff across Scotland by 2026, including ensuring that every GP practice has access to linked workers to support mental wellbeing. Funding will be issued to integration authorities, and Falkirk Partnership can expect to receive a maximum funding allocation of £277,000 in the current year, increasing to £553,000 next year, rising further to £1.116 million by 24-25. Planning group has been established to consider these funds, initially on a pan-Forth Valley-wide basis, mirroring the approach that was taken for primary care improvement plan. And as the project develops, the planning group will evolve to include wider representation, including third sector and experts by experience. Section 5.11 in the report notes that individuals should be able to access mental health and wellbeing and primary care services without the need for a referral from a GP. Services should make appropriate use of digital solutions, and people who require urgent care should be able to find pathways that are easy to access, quick and responsive at the earliest possible point. Section 5.12 continues by summarising a high-level plan that has been developed by the steering group so far, including a hybrid approach, complementing the primary care improvement plan model already embedded in general practice, and listing a number of additional posts, including various linked workers. Finally, in terms of the investment section of the report, the board will be aware that 4 wards at Falkirk Community Hospital have been closed for some time in response to fire-related health and safety issues. Staff were temporarily redeployed, but since then, the scale of work required to address the fire risk means it's not feasible to reopen the closed wards, and an option appraisal has been carried out to identify a preferred option to offer all redeployed staff opportunities within permanent vacancies across both the partnership and NHS Forth Valley. The potential recurring saving generated from permanent redeployment of Falkirk Community Hospital staff into budgeted vacancies is in the region of £2.1 million. At present, savings contribute to the overall financial position, and as such, the extent to which net savings could be released is linked to progress of savings delivery and the impact of other service redesign. It does, however, present a unique opportunity to accelerate a shift in the balance of care by reinvesting an element of the savings into other community-based services, particularly given current unprecedented demand for packages of care and current high levels of delayed discharges. Section 5.18 of the report lists a number of potential investment options, including a range of behavioural approaches, enhanced AHP input into community hospitals and care homes, community nursing and end-of-life care, care at home capacity, discharge without delay, third sector partnership working to extend community supports, and prevention, including work underway for care pathways. The board is asked to agree in principle to the reinvestment of a proportion of the Falkirk Community Hospital staff budget to augment community-based services, and request officers develop a proposal for consideration at the future IGIB meeting. That's also covered again in the recommendations. Finally, I would draw your attention to Appendix 1, which sets the directions to both Falkirk Council and Forth Valley Health Boards under the Public Works Joint Working Scotland Act 2014. The IGIB will make payment to the Council of £107.492 million and payment to the Health Board of £119.473 million to carry out the functions that are listed in the Appendix. In addition, the Health Board will make use of the sum of £35.548 million set aside in relation to large hospital services. In the recommendations, the Board is asked to note the year-to-date overspend of £53,000 as at 30th of April 2022, to approve the breakdown of payments to Falkirk Council and NHS Forth Valley per Appendix 1, to agree in principle to reinvest a proportion of the Falkirk Community Hospital pay budget underspend to augment community-based services, with a detailed business case to be presented to a future meeting, and to note the high-level mental health and wellbeing primary care plan that will be submitted to Scottish Government with regular progress reports provided to the IJB going forward. Thank you.
Okay, thank you, Stephen. Do we have any questions or comments for Stephen? Councillor Colley.
I'd be surprised if I didn't have a comment on this. Just in relation to the reinvestment of the funding from the community hospital pay budget, I feel very positive about this, because I think that it's what we've been talking about for as long as I've been involved in the IJB, and as long as I've been involved in integration, actually, around that movement from bed-based care into communities, and into the kind of services that also support people to live better lives. And I think going back to earlier in the pandemic, the investment in further AHP capacity in Bowness Community Hospital, for example, and actually what a difference that made to the individuals there, and they were able to go home earlier. And I think these are really important developments. So I just wanted to say how positive I feel about that. And I also wanted to note about the additional staffing in relation to link workers. And again, I think this is obviously an ongoing programme around community link workers, but certainly the connections as a local councillor that I've had with link workers, and the really supportive, coordinated approach that they could provide for individuals in the community, I think is absolutely excellent.
Thank you, Fiona. Stephen?
Thanks, Chair. Yeah, so I think the reinvestment is an excellent initiative. I suppose in looking at increasing our fuel bills, not only in our main sites, but actually have we considered the impact, because we're going to have another hit in October, on care at home, because we'll have vulnerable individuals being cared at home, many who may be in fuel poverty. So, you know, have we thought about that? Have we thought about what does a care package look like in these quite difficult times for people? Because you know, we all want people to be cared, or as many people to be cared at home as possible, but if they're kind of living in fuel poverty, what does that mean for us, that we consider that?
Thanks, Stephen. I'm going to ask Patricia to come in and respond to that.
Thank you, Stephen. You raise a really key point. The council is doing a range of work which we are contributing to in terms of tackling inequality, but particularly tackling poverty. And there's a couple of papers going to the council executive next week, which we've contributed to. So it will require that partnership approach across all the agencies. We haven't done anything specifically on that. We have tackled that, as you'll be aware from the papers, in relation to our providers who are coming and saying that some staff can't afford to put petrol in their cars, therefore they can't do the runs that they're commissioned to do. So we've dealt with that element of it, but this is a much more substantial issue, I think you'll agree, and we will actively pursue that with our council and community planning colleagues. So thank you for raising that.
Is that something we'd expect to see in a future Chief Officer's update or something? Yes. Okay, any other questions or comments for Stephen? Stephen, you're getting off lightly this morning. Obviously, they've been kind to you. It's your first meeting. Okay, then. If there are no other questions, then can we just agree that we will note, approve and agree the 4 recommendations as set out in the paper? Okay, I see no one who's disagreeing, so thank you very much. I'll take that as being approved. I would then like to move us on to item 8, which is the Falkirk Community Hospital Master Plan, the strategic assessment. And I'm going to hand over to Gail Woodcock, who will take us through this paper this morning.
Thank you, Chair. Yes, so this paper is on the Falkirk Community Hospital Master Plan Strategic Assessment, and it brings an overview of the work that's been undertaken to date. There's been lots and lots of engagement over the last year in terms of defining and starting to develop what the Falkirk Community Hospital Master Plan would include. It's important to stress that the Master Plan is a very high-level document and a very high-level concept in terms of the direction in which we want to go. And it aligns with the requirements of the Scottish Government Capital Investment Manual, and that's the process that we're working to as we progress towards the new Falkirk Community Hospital. We've considered the emerging models of care, and through the various workshops that have taken place, we've developed clinical briefs linked to community-based care to explore with stakeholders new service models. We've done this in a way that make sure that we're very integrated with the aspirations of the Falkirk IJB strategic plan, particularly in relation to intermediate care and the review of bed-based care, and our aspirations to continue to work in partnership with the third sector to support people, to care for people within their own communities. So there's been a number of work streams as part of this that have been progressed. The first one is on bedded care, and we've been looking at that overall bedded care model that we might need in the future, considering intermediate rehab-focused care, longer complex specialty care, specialist stroke rehabilitation, palliative and end-of-life care, step-up and step-down care, and the potential for housing and housing with care. We've also looked at ophthalmology, in particular diagnostics, outpatients, long-term conditions. We've looked at examples of best practice elsewhere and how we might take some of those examples to implement within Falkirk. We've looked at outpatients, including child and family health, mental health and psychology, community alcohol and drug services, amongst other aspects. Again, looking at new ways or examples of best practice we might want to use as part of our service design. Primary care links into another paper that is next on your agenda around the Primary Care to Capital programme. So aspects of this will align with the Falkirk Community Hospital Master Plan, so it's really important that we consider those together. And I won't go into that in further detail because there's much more detail coming in your next report. Decontamination, at the moment there's a decontamination unit on the site. What has been identified as well that is required, it doesn't necessarily need to be as part of the Falkirk Community Hospital Master Plan, so further considerations will be ongoing in relation to that. In addition, there are a range of technical services on the current site, but again, that doesn't necessarily need to be part of the Falkirk Community Hospital Master Planning approach. And also there are offices and accommodation, and there will be need for offices and accommodation on site, and some of the people who are currently on site don't necessarily need to be on that site, could be somewhere else in the Forth Valley area. We have agreed on concepts in relation to how we manage as offices and accommodation, which is very much in line with our partners, NHS and the council, in terms of moving towards flexible desk policies, etc. As part of the extensive engagement and consultation, a concept of a living well hub has emerged, and this is something that wasn't set out at the start, but through the various conversations has emerged as something that people are really interested to explore. And I would say it's very much a concept at the moment. It's an idea, and the concept is one around creating an opportunity for people to come together to self-manage their long-term conditions, to be able to access areas where they can check their own health and well-being. They can receive advice and support around particular issues, potentially come together from a social perspective, potentially through something like a community cafe, for example. So it's very much an emergent idea, but there's a lot of enthusiasm and excitement around that. So that is continuing to develop to define what that would mean in practice. The next section of the report goes through the various engagements that has taken place, and then we have the current timeline to submit the strategic assessment to the Scottish Government. It's important to stress the strategic assessment is not a document that requires to be approved, but we do require to submit it, and the Scottish Government may give us feedback on that as part of that overall process. We also have included an indicative timeline within the paper setting out the overall process that we need to progress. So we will now be commencing towards the initial agreement stage, and we think each of these stages will take around a year to progress. So it'll be the initial agreement, and then we undertake an outline business case, then a full business cases. And the reason it's business cases, there is obviously different elements to the master plan, and then construction and commissioning, and potentially some or all of the facilities might be available and operational by January 2028. And I stress the word indicative timeline and potentially, because there's obviously lots of things that can happen between now and then that might impact on the timeline. Finally, the Appendix 1 in your pack, you can see a fairly complex diagram which shows the actual master plan. It sets out what the need for change is, the linkages between the need for change and the anticipated benefits, the alignment of those benefits to the NHS Scotland strategic investment priorities and the solution that's being considered. So it's quite a complex diagram, but quite useful to set it all out on a page. I'm happy to take any questions. Just before I do, just to reiterate the recommendations, which are for the IJB to endorse the strategic assessment for onward submission to Scottish Government, and to note that work will now commence to progress the initial agreement stage.
Gail, thank you for that. I particularly look forward to, I like this concept of a living well hub as a connect, and I really look forward to seeing a bit more in terms of what happens there, you know, in the coming months and years. I think that's interesting. But I'll hand over. I can see David Heron, you have your hand up.
Yeah, thank you. I mean, this plan's really good, and it's really nice to see it progressing, and hopefully it will continue to progress at the pace that's been described in it. One thing that I think is in there that is easily forgotten about when we do these plans is accommodation for medical students. So I was really glad to see that in there. And we have a huge challenge in Forth Valley because we don't have a medical school in attracting students to come and work here. And so providing them with free accommodation to stay in while they have placements in our hospital and in our GP practices is really, really important to increase the awareness to these students of this area. You know, I know this is a nice place to live and work, but these people don't. Often they don't even know where Forth Valley is. So hopefully that will remain in the plan, and it's really good to see that it's in there at the moment. Thank you.
Thanks, David. That's a really valid point you make there in respect of students. Do we have any other questions or comments for Gail? Gosh, okay. We do not. Are we happy then to endorse and note the recommendations as in the report? Fantastic. You can see I'm assuming she's going to speak on behalf of you all, so we're absolutely fine. No pressure there, Fiona. Okay, I'd then like to take us on to item 9 on the agenda, which is the Primary Care Premises Initial Agreement, the PIA, and I'm going to hand over to Cathy O'Neill, who I believe has joined us.
Yes, thank you, Chair. Thank you for the opportunity to come along and present this paper. And as Gail said, it follows on very nicely from the discussion around the Falkirk Master Planning, and the two programmes are actually linked in terms of some of the work that we want to take forward for GP premises. So this paper presents to IGB members the final initial agreement document for a programme of capital investment in primary care premises. We hope it will benefit all practices across Forth Valley in some form or other, and it will also support the priorities of the partnership at locality level in terms of taking forward more integrated working and looking at some of those place-based priorities that you would want to take forward. Many board members participated in a workshop in March where we had the opportunity to set out the direction of travel and the proposed model of care. Hopefully some of this is familiar to you, but I'll briefly take you through the paper and highlight some key points. So this is a proposal seeking capital funding from the Scottish Government, and we are following the process which has been set out by the Government in its Capital Investment Manual. As it's a capital bid, the formal governance and approval process sits with the Health Board, which considered and approved this initial agreement at its meeting last week. We also have a programme board which oversees this programme, which is chaired by Cathy Cowan, and it oversees this and the Falkirk Master Planning Project, so that there's clearly, we're taking these forward together. At this stage, the initial agreement, which is a stage on from where the Falkirk Master Planning is, it focuses on services rather than buildings at this stage. It's about making the case for why this programme is a good thing to do. It's about setting out the key drivers, the key things that are driving this change, and importantly, the benefits to patients and to GP practices. As the Commissioners of Services, it's therefore important that the IGB is supportive of the direction of travel and that it's comfortable that this programme of work will meet its needs and the local priorities that the board have. The next stage, which is called an outline business case stage, is where we will get into the detailed options around premises solutions. I'll ask David Heron, Dr. Heron, to say a few words at the end about the importance of this programme for GP practices. But in terms of the key drivers, the implementation of the 2018 GMS contract is clearly fundamental to this, and the transformational work that we've been taking forward in Forth Valley around GP sustainability. This has seen a significant expansion in the wider multidisciplinary team, so mental health workers, advanced nurse practitioners, physiotherapists, etc. And that is looking at an extra 200 staff across Forth Valley, and we need to be able to support them practicing and delivering their services. There's other additional demands on practices to be aware of. There are significant housing expansion in many areas across Forth Valley, and Forth Valley is somewhat different from other health board areas in Scotland, where there is an overall increase in the general population. You will also be aware, and you'll have discussed many times, the demographic changes that we're seeing, which will bring both more demand and more complex complexity to the work of GPs. The paper that you have in front of you sets out the engagement that we have taken through to work through all the options, and we are very grateful to the IGB and the partnership who have helped us enormously and many members of the SPG, for example, have been involved in some of the workshops that we've taken forward and have helped us to craft and develop our options. The model we're setting out the proposing is set out in Table 1, and this shows all of the elements of the model. In terms of the minimum service, we want every GP practice to have enough space and capacity to deliver on their contract, their kind of core contract. And the rest of the model is really about those wider services, the wider MDT, the wider community services, and how we can look at, on a locality basis, how we can look at what is the best configuration in each locality, and it will look different depending on what we currently have in the locality and where the gaps are. Table 2 gives an indication of what that might look like in each locality, but it will be when we get to the outline business case stage that we will look at that in more detail. Table 4 in your paper shows the process that we have been going through to get approval and endorsement of the case, and we're almost there now. So we've been through the board, we're here today, and we're going to the club manager and Stirling IGB in a couple of weeks. The PIE has been submitted to the Capital Investment Group, and we've had confirmation that it is on their agenda for the 29th of June discussion, which is great. Table 5 then indicates how we will take forward this. Once we get approval to the IEA, we will then work on locality-based business cases, and we will do that over the next. That will take time, as Gail indicated. All of these business cases will take a period of time. We've given some indicative timeframes, but it really depends on approvals and getting the Scottish Government to give us the approval to move to the next stages. We've also indicated in the paper the priority that we plan to work through, the priority localities, as we plan to work through them. Note that this programme will support 4 locality business cases. The 5th locality business case, which is Falkirk Central locality, will be taken forward through the Falkirk master planning process, and that's why it's important these 2 programmes kind of move forward together. So coming back to the recommendations, we are asking the IGB today to endorse the initial agreement document, and to note that once we get approval, we will then take that forward through our locality business cases. And I'd just like to finish just by handing over to David, just to kind of say a few words on behalf of the GPs about how important this work is.
Yeah, thanks, Cathy. So yeah, I certainly hope that IGB will support this plan, and actually as many of you as possible will continue to support us in this as it progresses over the next few years. Obviously, it's important to point out there still is small scale improvements going on in lots of Falkirk practices every year. But if we want premises that are fit for the future, then we need this sort of bigger scale plan going forward. I think if you went out and asked the people of Falkirk at the moment what is their #1 priority for healthcare, I think a lot of them would say it's the ability to see a healthcare professional at a GP practice when they feel ill. And there's a lot of factors that make it difficult to provide the capacity that we need for that. But one of them is very much accommodation. So, we are struggling, and practices are unable to provide as much clinical contact as they would like to, partly because of accommodation issues. So let's get rid of this as a reason for not being able to deliver that. So hopefully we can support and push this plan forward as fast as possible. Thank you.
Thank you. So happy to answer any questions. Thank you.
Okay, thank you, Cathy, and thanks, David, for coming in there at the end as well. And I can see Councillor Fiona Colley has her hand up.
Thank you. I think obviously very positive around the development. I think looking at my own patch in the Falkirk West area, I know that there's a lot of certainly at least a couple of the practices where space is at a premium, and it's very difficult to expand to provide different services in the space available. I suppose my question was around the involvement of the community and early stage in terms of what they would like to see, because I think some of the changes around the really positive changes, for example, mental health nurses might be a really good example of that. Community link workers in practices. I think sometimes it's not been necessarily as well understood by the public about and patients about what those different options are and why they're not seeing their GP. So I'm thinking that there's just something around this being a really good opportunity to really work with the community at the earliest stage to say this is what we're looking at and this is why we're doing it. And what do you think of this idea? What would you like to see if there was a locality hub? What would you like to see in it? What would be important to you? So I suppose it was a question about when the opportunity comes in, is it something that's threaded through the whole process? So that's my question.
Thank you, Fiona. That's a really important question, and I think we thought a great deal when we were going through the initial agreement process about the extent of the engagement that we did. And we did talk at some points about going out and talking to GP populations, to GP practice patients. We didn't do that at that stage because this is a programme which is looking across Forth Valley. It's all quite conceptual at this point, and we didn't think that was the right time. So we engaged with a lot of patient and representatives and carers, but we didn't go out to GP practice populations. When we get to the outline business case stage, and we're talking about Meadowbank Health Centre and what we're going to be doing there and what the options are there or what the options are in that locality, I think that's when we will start to go out and talk to people more directly about exactly what you've just described. So, and I think that will be more meaningful because we will be talking about their practice and their local area and their local community rather than a kind of broad conceptual thing about hubs and spokes and what does that mean.
Thank you, Cathy. Fiona, anything you want to come back in on there?
No, that's great, thank you.
Okay, thank you. Just wanted to check. We have someone before Morgan. Let me see. Gordon and then Morgan.
Thank you. Yeah, I'm very supportive of this programme. Had the opportunity to see it through the health board. I think, as David said, there are a number of barriers people have to healthcare, and I think the ability to bring more services closer to people is going to be an important part of that, and is a lot of the direction of travel that I think we're going in terms of early intervention and prevention, in terms of keeping people well rather than treating people when they become unwell. So I think this all makes perfect sense. I think that the one thing I would say is that when you're running a programme like this that isn't going to come on stream for a number of years, you kind of need a crystal ball, really. So I guess the difficulty in all of this is thinking not about what healthcare services people are going to need today, but what healthcare services people are going to want and need in 5 or 6 years' time. So I would hope there is a bit of flexibility and spare capacity built into the plans when we get to that stage, so that we can add in things that right now we've probably not even thought about adding in. But you know, the last thing we want to do is spend a lot of money and create new premises that become obsolete almost the moment they're there because they're then not big enough. But I'm sure you've thought about it.
Absolutely, it's a huge challenge, but absolutely, that's exactly what we need to do.
Morgan?
I wanted to reinforce the point that Fiona made. I think it's really very, very important that when something as big as this is happening, and it's going to be so beneficial, it's really, really important that we do take the public with us, that they know what's happening all the way along the line, and not here right at the very end, this is going to be a massive change, and they feel as though it's been forced upon them rather than they've been involved in it. So I think it really is very important to involve the public with it. Thank you.
Patricia.
Thank you, Cathy. It's an extensive paper and a great piece of work. It was just really to add to what other colleagues have said and really flag up that certainly Falkirk Council, and I would imagine Stirling and Clackmannanshire councils would be in the same place, but actually looking at their asset planning across the whole of the portfolio. So there may well be opportunities around development of locality hubs in relation to provision of schools, provision of early years facilities, leisure facilities as well. So it's really important that we're making the connections early and frequently so that we are trying to align any potential opportunities for joint investment in terms of that public pound and getting more for the public pound. So it was really just to flag up that there is and there will be opportunities, but we'll need to be really alert to those. And I appreciate there's 3 local authorities, but from a Falkirk perspective, you know, we're very keen. The discussions that I've had from the partnerships perspective with colleagues in the council is that they're really keen to get around the table on any of those opportunities. Thanks.
It's very important.
Yeah, thanks, Patricia. That is an important point, and the outline business case process requires us to do that. So it requires us to go through a very detailed option appraisal process, which includes not just looking at new buildings, but looking at the options to do those joint investments or to look at accommodation, which sits in the broader sort of public sector. So all of that will come at the next stage when we start to get into that really detailed option appraisal.
Thank you, Kathy. Any other questions or comments for Kathy? No. Okay, then are we happy to endorse and note the recommendations as set out in Kathy's paper? That's great, thank you. Thank you very much, Kathy, for coming along this morning.
Thank you very much. Thank you.
Excuse me. That then takes us on to item 10 in the agenda, which is the review of the strategic plan for 2019-2023. And I believe we have Leslie MacArthur this morning who will talk to this paper.
Thank you, Chair. Good morning. Yeah, the purpose of this report is to provide information to the board about the review of the strategic plan for 2019 to 23. So just by way of a background, the Public Bodies Joint Work in Scotland Act requires integration joint boards to produce a strategic plan and to review this at least once in every relevant period. The relevant period is defined within 3.2 of the report. The plan has run in 3-year cycles from the start of the integration process. The plan sets out how the IJB will plan and deliver services over the medium term using the budgets under its control. It describes how the IJB will deliver the national health and wellbeing outcomes and achieve its core aims. The Strategic Planning Group has a key role in the review of the plan and is required to make recommendations to the IJB about whether the plan should be kept or replaced. In September 2021, the IJB agreed to extend its plan for a further year to 2023. This decision was informed by a joint workshop with the Integration Joint Board, Strategic Planning Group and senior leadership groups. In order to inform and support our next strategic plan, a significant range of associated work is required. This includes a detailed strategic needs assessment, a medium-term financial plan, housing contribution statement and integrated workforce plan. It's of note in terms of the integrated workforce plan that this must be developed in line with Scottish Government guidance and should be published by the 31st of October 22. So work has already started on the development of that plan. Throughout the process, consultation and engagement is critical in terms of ensuring people, community, staff and partners are able to be fully involved in the co-design process, and that will include the community planning partnership as well. The Strategic Planning Group participated in a session to initiate and progress the review of the plan in May 2022. The group made some initial recommendations at that point that COVID recovery should be considered as a cross-cutting theme across all areas of provision, that wide consultation and engagement regarding outcomes and priorities was critical to the development of the plan, that outcomes should reflect the need for enhanced joined-up working practice across the partnership, and also that a logic model approach should be taken to identify any gaps in terms of the priorities and how we achieve our outcomes. A high-level timescale was also proposed, which is shown at 4.14 of the report and culminates in the publication of a refreshed plan on the 1st of April 2023. The timeline has been developed to provide maximum opportunity for effective consultation and engagement to be undertaken. Section 5 of the report highlights work undertaken to review the Strategic Planning Group's terms of reference, which have been approved by the group itself. The revised terms of reference is provided as Appendix 1, and the key changes are that the Strategic Planning Group has a role to monitor the implementation of the IJB's directions policy, and also that HSCP localities are included within the membership of the Strategic Planning Group. The recommendations of this report are therefore that the IJB approve the review process of the strategic plan as proposed by the Strategic Planning Group, and also approve the revised terms of reference for the Strategic Planning Group. Thank you.
Leslie, thank you. Do we have any questions or comment from Leslie? No. Okay, on that basis then, are we happy to approve the recommendations as set out in the paper? Yes, thank you very much. Okay, that then takes us on to item 11, which is the performance monitoring report. And I believe we have Callum this morning who's going to take us through this report. We're running quite early this morning. I don't know what I've done. So I don't know if Callum just hasn't joined us yet.
No, sorry, I am here.
Apologies, Callum. I'll hand over to yourself.
Don't worry. Thank you, Chair, and good morning to members of the board. The Performance Monitoring Report presents the board with a summary of performance up to March 22 and provides a year-on-year comparison with an indication on direction of travel. This iteration also includes a briefing of the recent local government benchmarking framework publication by the Improvement Service, which is at Appendix 3 of the full report, and I'll come back to that shortly. First, just to look at our regular local performance indicators, and as before, there is a focus on exception reporting, and I'm now just going to take you through some of the key areas highlighted in section 1 of the main report. The report highlights there are continued pressures around emergency department 4-hour compliance and around delayed discharges, and sections 3.1 and 3.3 of the report provide some further detail on that, as well as some of the actions ongoing to support these areas. There were 37% more adult protection referrals in 21-22 compared to the previous year. And for assurance to the boards, the Adult Protection Committee continue to oversee activity in this area. The report highlights the number of complaints received across both health and social work, as well as the percentage of complaints responded to within the timescales, and also some of the main themes of the complaints received. For social work adult services, 75% of complaints in 21-22 were responded to within timescales, and for NHS services, 81% were responded to within timescales for the period April to February 22. For social work adult services, the overall sickness absence figure for 21-22 was 12.9%, and that's an increase from 9.9% in the previous year. For NHS services, the overall February 22 sickness absence position was 5.6%, and that's a slight increase from 5.2% in the previous February. The report details the latest positioning for waiting times for psychological therapies, and in March 22, 80% of patients started treatment within 18 weeks of referral. And that's an improvement from the previous month, and also significantly better than the performance in March 21, where it was just under 64%. And encouragingly, it's also ahead of the remobilisation plan trajectory of 60% by March 22. The number of people receiving either a community care assessment or a review in 21-22 rose by nearly 18% compared with the previous year. And when we consider that increase against the significant challenges around recruitment, retention, and also high absence rates, I think this is a testament to the hard work and commitment of the staff. And lastly, from the local indicators, the report also outlines the number of overdue occupational therapy pending assessments, which was 292 at the end of March 22, and that's remained pretty much static since the end of the previous quarter, when it was 290. Appendix 3 in the full report contains a briefing from the recent publication on the local government benchmarking framework, and this is it's a really helpful tool for us, as it allows us to compare ourselves both to the national picture and to our peer group. Similar to our approach for the national indicators last year, we've included a performance at a glance section that categorises how we compare to the national average for the indicators included in this publication. We've created 3 categories, and the first one was performs better than the Scotland average, and we've defined that as anything greater than 2 percentage points better than national average. The next category was similar to Scotland, so that was anything within a 2% percentage point range. And the last one was does not compare well to the Scotland average, and that would be anything out with 2 percentage points. Out of the 11 indicators, there are 5 where we compared favourably to the national average, and those indicators included the percentage of people aged 65 and over with long-term care needs who are receiving personal care at home, the percentage of adults supported at home who agree they had a say in how their help, care or support was provided, the percentage of carers who feel supported to continue in their caring role, residential costs per week per resident for people aged over 65, and lastly in that category was the proportion of care services graded good or better in care inspectorate inspections. There was a further 2 out of 11 indicators where we were in a similar range to the national average. And then lastly, there was 4 out of the 11 indicators where we compared less well to the national average. And those indicators were home care costs per hour, self-directed support, the rate of readmissions, but I would refer to the paper from the March IGB, which explains that the significant increase in the latest year in the national publications was largely due to a change of recording in terms of how the assessment wards were recorded locally. And then lastly, delayed discharges. So in terms of recommendations, the board is asked to consider and comment on the content of the report and to note that appropriate actions continue to be taken to address the issues identified. Thank you for listening, and happy to take any questions the board may have.
Callum, thanks for that. It won't surprise you, this is always a report I find really interesting, and the addition of the summary of performance is particularly helpful with that. I'm seeing it in black and white, so I don't know what colour it is. In my head, I think it looks like a kind of rag rating or something. I don't know what colour it is. For me, I suppose the 2 that are a real concern, and I'm not looking for you to answer these, I just want to note it in the meeting, is the delayed discharge and the readmission to hospital, that we really are sitting quite far out there, aren't we? So those are the ones that concern me more than necessarily home care or self-directed services. As always, like I say, I find these reports really interesting. I don't know if any other colleagues wish to comment or have any questions for Callum or his colleagues. Gordon.
Yeah, as you say, Chair, there is a massive amount in here and some really good information and some real highlights for me. You mentioned the psychological therapies figures, Callum, which are very good, as are the substance use figures. I think we're showing some very good results there. I was going to raise delayed discharges as well. I know this is an ongoing issue and one that's a source of frustration to everyone in health and social care. I think what stood out for me looking at the figures and indicators 54 to 59 in the report is that not only are the number of delayed discharges going up, but the number of bed days has gone up quite considerably. So it would seem that not only are there more delayed discharges, those who are delayed seem to be being delayed for longer than in the year before, which is something I think we need to look at. So I know there has been a great deal of work done across health and social care to try and resolve this position, and I know that staffing difficulties have a lot to do with it. But I think it's something that we do need to have another go at and to try to rectify the position, because it is resulting in a lot of difficulties both for people and for systems.
I don't know if you want to come in on either of the points made by myself or Graham before I hand over.
No, I would agree with Gordon, and you know, we are seeing those delayed discharges. The pressures are clearly ramping up, and I think that is a position that is reflected in the national data as well. We're not alone in that area, but it's obviously a key area of concern.
Yeah. Thanks, Callum. Okay, I'd like to hand over to Roger.
Thanks, Chair. Just on a couple of those points, I felt from my own experience have come in that, firstly, the self-directed support figures. I always feel these are a bit unhelpful to see it as polarised, that it's all bad having low self-directed support figures. My experience of working with service users is often that if they're getting good service directly from the council, then they don't look necessarily to self-directed support as an alternative to good service. So it isn't quite clear to say that just because these figures look poor, we're told they're poor compared to other local authorities, local areas, that they're necessarily a poor sign of the service that's been provided. The other issue is that the delayed discharge, which many of you know that I'm quite involved in that in my day job. I would suggest that there's quite a lot of things that Falkirk can still do to reduce those figures quite significantly and quite easily. And I'm always disappointed that there isn't more coordination with frontline workers there, and communication with frontline workers and some of the issues. So I'd welcome more more work with frontline workers because I feel that we could reduce those numbers quite quickly in some areas, particularly with the AWI numbers.
Thanks, Roger. I would agree in terms of your first point around self-directed services, and often, what does it actually mean? Is it good or bad? I think it also, I suppose I also highlighted the issue around delayed discharge as well. And I can see Councillor Colley has her hand up.
Of course I do, always. I suppose I'll put the alternative view in relation to self-directed support. I think that I have, and Patricia will know this, have a strong belief that we should be looking to try and increase the flexibility and the different options, and it is about availability of different options and people understanding that. But I am also aware in the challenging circumstances, not just for the council but for voluntary and third sector partners as well. So some of those options in relation to self-directed support is not as cut and dried as a council service or a direct payment. So I think that there's something about trying to continue, and Falkirk has a good reputation in a lot of its self-directed support work, so building upon that. So that is definitely something that I would like to see. But I think that there's something that the bit that as well as the days spent in hospital in the Scotland the comparator is the bit about readmission rates, because to me that is something quite concerning, and we have had a report about it which I felt was very helpful, but I think it's something about keeping an eye on that, because does it tell us something about discharge? And it may or may not. Sometimes it might, sometimes it might not. Does it tell us something about the support people have in communities? And I suppose it's trying to, on an ongoing basis, dig down into that, rather than on whether it's something like an annual report about readmissions, but being able to understand that every time that we get performance monitoring and trying to dig down into some of the answers behind that. And I know that none of it is simple, and certainly none of it is simple at the moment with the ongoing pressures.
You're absolutely right, and I guess if we assume that the data recording is sound, that other areas across the country are managing it, so why can't we? No, I think that's it. Any other hands? Callum, sorry, you're waiting patiently to come in, and I'm bumbling on here.
No problem. Just to come back on that readmissions point, and to stress the importance of the paper that we seen in March. It shows a big spike. The chart that's in the paper today, it shows a big spike in that latest year, but just to stress that big spike is largely due to a change in data recording. But what I would say, for further context, is even before that big spike, we were slightly above the national average anyway, but we're not to the degree that that change in recording has put us now. So just to add that context.
Thank you very much, Callum. And I can see Councillor Devine, you would like to come in?
Hi there. Yeah, so I just kind of wanted to kind of put my 2 cents in about the delayed discharge. Obviously, I've got huge concerns when it comes to delayed discharge, especially given with the pandemic, and we've seen huge deconditioning of people, which then, of course, if they're delayed, they're going to require, more and more service. And then the readmission rates. I see it in my old job. I was a manager in housing and care. So I seen it firsthand, how much of a negative impact that can have. And also that will put a further strain on the services, especially at a time where we are working within limited capacity. So I just wanted to add that point too. Thanks.
David, I can see you've got your hand up, but I'm going to put Patricia on the spot here, so apologies, Patricia. Is there, in the coming months, I know we have our set agendas, is there something that could come back to the IGIB? I appreciate it's much wider than
so there's a number of things going on and have been going on in terms of delays in discharge, and absolutely 1 day longer in hospital is not good. If you're in the wrong place, it's absolutely not good for anyone. We do have some issues at times around coding because, you know, we find in the hospital we're all working on different lists and the data we have is not the data. So there's an issue about the current changing situation and some of the classification of delays. There's a number of areas of work that Gail is leading on with colleagues in NHS Forth Valley around discharge without delay, looking at earlier, there's been pilots in a couple of wards to look at earlier discharge. What's been happening over the last 6 months or so is later and later in the day discharge, and that then can lead to additional days in. If people can't get transport, can't get people, care homes won't accept people after 4 o'clock because they've not staff to do that reception and settling in of new residents. So there's a number of other systemic issues that can contribute to that creep. It's unfortunately we don't have a countermeasure, a balancing measure, because we're measured on the negative. We were above the national average pre-COVID, but we've had huge increase in activity, huge increase in demand. The hospital demand is only about 40% of our demand, so we're meeting the other, you know, there's the other 60% demand that we've also got to meet. Since December, between December and the end of April, over 1,000 additional people were helped out of hospital through the third sector initiative that we've reported. So we don't want to be in this position. We're doing a lot of work with colleagues in the NHS, but it actually belies, you know, there's a 39% increase in adult support and protection, 37%, sorry. So there's increased activity across a number of areas, and we need to understand how our performance sits against that, notwithstanding we need to be able to meet that demand and we need to find ways of meeting that demand. So Scottish Government have asked all health boards and partnerships to do a bit of a self-assessment against unscheduled care, which has to be in next week. So I think we've been given a couple of weeks for that. So we're working on that with the medical director and other colleagues in Forth Valley. I think what we have to be really clear across the system that we're talking about apples and apples and pears and pears. I think the volume of activities maybe introduce a bit of slippage in that, and we've certainly come across that in some of the calls with the hospital, that the numbers that we're dealing with are different from the numbers the other colleague. And sometimes that's a timing issue, when ward rounds are done, when the data's updated, when the administrator actually puts the data into the computer. So there's a number of issues there, but just to give assurance to the board that we're absolutely vigilant around this, and there's been a significant focus and effort that's not showing through in the data that you're seeing today, but we will, and I'll certainly pursue with Roger, because I know Marlon Gardner's been raising a lot of work around AWIs with support from legal, NHOs and other colleagues, so I'd be interested to have further discussions about adults with incapacity particularly, because we do have significant numbers in that regard. I don't know, Gail's got her hand up, and I know David has. I don't know if Gail maybe wants to come in some of the detail.
Okay, thanks. Gail, do you want to come in?
Yes, thanks, Chair. Yeah, just to build on what Patricia's been speaking about, so the delayed discharges is one indicator, and as Patricia says, the actual quality of the data that's used for that indicator isn't always as perfect as we would like it to be. It's one indicator that shows the impact of a really complex system, and there's a range of different factors that play into the situation that we see, and of course we want people to be in the right place for their care journey at the right time. So there's a range of different pieces of work that we're progressing as part of our Discharge Without Delay programme. One of the pieces of work we're looking at is around the way the team works in the hospital. So it's the integrated discharge team, looking at the processes that use the single shared assessments to make sure that's as streamlined as possible, and to make sure the communication is as good as possible with the patients who are in hospital, who are ready to come out as well, so they understand what the situation is. We have staff shortages across the whole system, as everybody is very well aware of. So that might mean that people who are ready to come home can't immediately come home because we aren't able to provide those packages of care. So we do have other options around intermediate and interim care. We've spoken about the bed-based care earlier. One of the things that we're noticing is there's a higher proportion of people that need longer term rehabilitation. So we have Summerford that provides sort of 4 to 6 weeks rehabilitation, but we are seeing more people that need a longer term rehabilitation journey. And we are seeing that we don't necessarily have enough beds at the moment within our system to support that with the wraparound physio and OT support in relation to that. So that's part of the work that we'll be doing around our interim bed-based review. And we will be bringing that back to IJB over the coming months. In addition to that, we're looking at some of the factors that influence whether or not people are able, care homes, for example, are willing and able to accept admissions from hospital at different times. So we've been gathering what we call incidents of things that haven't gone as well as we would have hoped, and looking at what was it that didn't go as well as we would have hoped, and how can we improve the processes to make sure that, for example, if somebody is coming into a care home at the weekend for admission, the care home has the confidence that the person will have their medication, will have all their notes, will have been properly assessed, for example. So they have the confidence to continue to accept admissions when it's the right time for the person who needs the care. So this is a really complex area, and it's about the whole system. It's not just about what happens at the hospital, it's about what happens in the community, what happens across our various different types of residential, intermediate care, or long-term care. And we are looking at a whole range of different factors and making improvements as we go as well. I think it's really important to stress. And I think the teams are working incredibly hard under incredibly challenging situation to make sure that we are able to deliver the very best possible care in the right place at the right time to meet people's outcomes.
Gail, thanks, that's helpful. David, I can see you're patiently waiting to come in.
Yeah, I mean, Gail and Patricia have outlined a lot of stuff that's going on, and I don't have a massive amount to add, but I think focusing on readmissions is a really important thing. I agree with Fiona, and often not interrogating the data too much, but more just looking at the solutions to avoid a readmission. And certainly from a medical point of view, in 15 years, people are coming out of hospital a lot earlier than they did when I started here. And that's a good thing, but it does mean people will end up back in hospital more often than they did previously. But what we need to explore the ones that shouldn't end up back in hospital, and as GPs, we know a lot of the reasons why that is. When it's a medical reason, we don't have a discharge letter, so we can't work with the patient when they come out, is one of the big challenges. And there is a piece of work going on with our hospital colleagues at the moment to try and improve that. And I really hope that does work, because the patients need to know when they're discharged what went on in hospital and what the plan is for them. And likewise, those that are looking after them in the community, the GPs, need to know as well. So I think that'll go a long way to avoiding unnecessary medical readmissions. I do appreciate there's other reasons for readmissions beyond medicine as well. So it's really important looking at the solutions, I think, rather than just interrogating the data. Thank you.
Okay, thank you, David. Councillor Colley, I can see you've got your hand up.
Yeah, sorry, just a final. Well, actually, David said something there that I thought was the point about letters, and I think that actually the importance of them to families as well, so that the families have the right information when someone is discharged as well. But I thought, Patricia's point, and I think that about that counterbalance. And I think we don't really, and it's probably something that I think I talked about at the very beginning when I first joined the IJB, was about what we measure, and that actually having that measurement that says what are the successful discharges, and obviously that point about learning from them, but the number of successful discharges, where the teams have put in place the support that people need, but instead we focus on the delays in discharge. So I think there's just something about making that and I don't know how simple that is in terms of the data that's available, Callum. I suspect it's not as easy as I might like to think it is, but I think that balance, I think, is really, really important, because everyone's working really hard to try and get this right, and yet the things that get the headlines, and I'm going to apologise for using this term, bed blocking. And that's because of the focus on delayed discharge without necessarily that counterbalance that says actually how many people have left hospital successfully with support.
Yeah, no, absolutely. If you're right, Gail, you want to come back in on what Councillor Colley has said?
Yes, I was going to, if that's okay, Chair. So, Councillor Colley, so there is a measure that is measured, and that's discharges without delay. And I was trying to find the actual figure, and I can't find it quickly, but we're around about 97 to 98% of discharges without delay. But that includes all discharges, including people that don't need any support. What we're discussing at the moment is if we can have a measure that's discharges without delay for people who need a little bit of help in terms of the next stage of their journey, because I think that would be quite meaningful, because when you see it 97, 98, it sounds like it's really, really good. But of course, in terms of the number of delays we have, is we wouldn't want to be in that position. So that's one of the things we are looking at in terms of how can we get balancing measures and meaningful measures that allow us to celebrate the success, which hopefully we will have.
Yeah, Gail, I think that would be incredibly helpful to see the data in that way. Yeah, I can see that, excuse me, Councillor Hannah, you have your hand up. Would you like to come in?
Yes, I totally agree with David's point that we need to look at the solutions rather than just the problem. But I do wonder if we have easily separatable statistics on both delayed discharge and readmission rates, and which are from care related to care homes and which are related to people in their own homes, because it seems to me that the solutions in both those different situations will be very different. And I don't know whether the data is easily extractable or if it's not.
Okay, who wants to come back in on that one, Gail or Callum?
I'll quickly come back on that one if that's okay. So yes, certainly for delayed discharges, we can break it down into reasons, so we can see whether it's related to a care home placement or whether it's related to a package of care. So that level of detail is available, and we can include more of that for the next report if that is helpful.
Patricia?
In terms of readmissions, I understand from previous discussions, the medical director can identify if people have been readmitted from a care home. It's something that the NHS is vigilant about.
Okay, so I think it would be valued then if Callum is able to link in with his health board colleagues to determine what data is there and what would be meaningful then to share with the IJB. So Callum, you've got yourself a task. So thank you very much. Any other questions or comments? I think probably this is the longest discussion we've had about performance reports, which I'm particularly pleased about. Sometimes I think I don't know if when the agenda's long, we let it go through. So I think a big well done to us. I don't mean to be patronising, I appreciate that sounds patronising. Okay, are we then happy to note the recommendations in the report Callum presented today? Fantastic, thank you very much, colleagues. That then takes us on to item 12, which is a report by our Communications Officer, Paul, and I can never pronounce your name properly. I think it's Surgeoner. Apologies if I've got it wrong. So, Paul, you're going to take us through your wonderfully pretty comms report.
That's absolutely spot on, Michelle. Thank you. Thank you for that introduction. Hello, I see some new faces in the room, so I'll just quickly say hello to you all, and it's lovely to see you, and especially lovely to see some of you in the same room, which seems such an alien concept, so it's very welcome. So at the last meeting, we agreed to introduce a new quarterly comms update. So the last one was a bit of a test run with a template. So here we are with the first one that covers Q1, January to March. And I'll talk through it. And as you see, it's as well as a comms progress update on how we use our channels, our social media and things like that. It also provides a really good summary of what's going on elsewhere across the partnership. So service developments and whatnot. So it's a good snapshot of what's going on and keeping up to date. So on the first page, we've got a snapshot of the metrics that we measure. So you'll see that we've received 18 pieces of coverage across the media. So that includes our key targets of the Falkirk Herald and Falkirk Live, as well as the Daily Record, STV and Central FM. So we've introduced that new metric of reach or opportunities to see. So across those 18 pieces of coverage, it was over 238,000, which I appreciate is quite a high number, and it is based on sort of published circulation figures for each of those. But you'll see in the appendix there's a full list of all the pieces of coverage that were received, and you'll be able to see how that 238,000 is attributed to each piece, and it's quite useful to see that sometimes and see a package of activity and how much of a share of that number it takes up. On our social and digital channels, you can see that across all of them, so that's Facebook, Twitter and LinkedIn, we've had a reach of over 56,000, and that is really helping to signpost to our website and the news posts that we post on there. And you can see that the social media now accounts for 16% of all visits to the website. And if we look at the same quarter and we compare same quarter last year, that was 0%. So from a standing start to 16% is really positive, and shows that we're directing audiences to the messages and to our content, which is nice. And while recording our HSCP page, we also record the performance of the Living Well Falkirk platform. So you can see that in those first quarter this year, we had almost 1,500 visits, and people, while they were there, assessed over 126 individual areas of need. So you can select multiple areas at once, so that's 126. So that's not indicative of 126 people, but that's the individual areas that have been assessed. On page 2, we cover the services and projects which are featured in the media proactively. And if you were to summarise Q1 this year, it really is on 2 subjects. So it's funding opportunities and adult support and protection. So with funding opportunities, we've had 2 chances to shout about the Community Choices funding programme. So we had the small grants section of the programme announced the 26 groups that received small grants earlier in the year, and then a month or 2 later we had the 19 projects which had the larger place-based capital funding, and that did take up quite a bit of that 238,000 reach. So we got quite a good spread of coverage for the Community Choices programme, and we're able to, especially for the larger projects, able to pull out a few case studies and display the examples of the funding that's been spread in amongst the communities. Elsewhere on funding, we had our policy officer, Jennifer, attend the CVS Falkirk Virtual Funders Fair. So we had the coverage in the lead up to that, and then after that, or at that, we launched the Health Inequalities and Wellbeing Fund, which is a new pot of money aimed at reducing social inequality and health inequalities across Falkirk. And we've had a successful and well-received first application deadline. The next deadline is next Friday, so I will use this opportunity to plug that. And please, and thank you all for actually sharing the last sort of call out to say that deadline is coming, because that is really useful to reach as many audiences as we can. And then moving on to that second sort of topic of Q1 was adult support and protection. So earlier in the year, we had the findings of the joint inspection report published in February, and that came at quite a good time. And it was positive results as well. So we were able to coordinate a joint release with HIS, the Inspectorate and Police Scotland, alongside an internal staff briefing to sort of, because it's quite a lengthy document, so to summarise that and get the key messages across. And that achieved quite a wide range of coverage as well, including Central FM, that had a small broadcast with Alan Small, the chair of the Adult Protection Committee. And that piece of work alone had over 35,000 opportunities to see, which was extremely positive. The report, absolutely coincidentally, was incredibly well timed the same week as National Adult Support and Protection Day. So that week we were able to share the findings, promote the Scottish Government's national release, and produce a themes newsletter on the subject. So that, again, a bit of positive internal communications there, which was great to be able to do. On page 5, you'll see a summary of the activity led by external interests. and I don't think there's particularly any surprises there. That the topics are around sort of delayed discharges, which we were just discussing, especially that comes up around the publication of national stats and sort of how we compare. Again, on COVID recovery, so some interest from media on how we are reopening services, how we're adapting, things like that. Again, not particularly a surprise. And then unfortunately, quite a few media queries which sort of focus around the Scottish Government's Respect campaign. So just about how health and social care staff are receiving quite a large amount of abuse. And we do have the Respect campaign toolkit, which we deploy and we use to respond to media queries and use on social media as well, which is unfortunate we have that subject, but quite useful to have that Respect campaign toolkit and be able to deploy it. And then on the following pages, we have how we've been doing on social and digital updates. So you can see that we've got some tweaks to the homepage. So we've just simplified the info that you see on the first page, moving that information in the About section from the home section to the About section, and combining the meeting info that used to be on its own page is now on the main IGB page. So it's just a less scrolling and more logical, less clicking around the website to find the information that you need. A larger piece of work that's been going on with the website is the accessibility work stream. So that is making sure that all of our documents meet public sector regulations for accessibility, and also aligning up with the new council accessibility document policy. So it's a bit technical, but we've been reviewing the documents to make sure they've got things like alt text and proper headings and colour contrast and things like that. So we've been going through and made quite a bit of progress. So all documents have now been reviewed and updated. There are a few remaining ones which require a complete content refresh. So we're working with the sort of individual teams that own those sort of subject matters to make sure that we update those as appropriate. And then the page 10, we look at internal comms. So we did a bit of work in January to pull together some brand guidelines in a toolkit, which is on a new colleague hub page and is ready to be shared more widely. But we've had, during that time, we had sort of a test group of SLT and the policy colleagues, and it's a set of guidelines of how we talk about ourselves, pulls together some resources, sort of like stock images and in-house imagery, how we just talk to service users, how we talk about people with disabilities and things like that. So there's some really good advice and guidance in there, and then some templates about reports and agendas, and so just to make all of our materials that we put out consistent, which is fantastic. And then there's a summary of the partnership post, which is the monthly newsletter, so you can click through and see that if you've missed it. And then also just a note about the parliamentary monitoring or sort of colleague monitoring sort of we've sent around in the past in that quarter, which cover COVID announcements and developments on the National Care Service consultation, etc. And then lastly, if we look forward on upcoming activity, so the next few weeks there is the NHS Scotland event, and fantastic that we were able to take a poster to that, which focuses on the Winter Pressures Home from Hospital project, the delayed discharge project that we've been working on in Forth Valley at the moment. And alongside that poster, we've also got a joint press release which is doing the rounds of tweaking at the moment, so we'll be able to shout about the progress and the impact that project has already had, because of course it's been extended from its pilot base, which is nice. And then also there's a note of the awareness days, so things like Scottish Breastfeeding Week coming up and Frontline Workers Day that we'll do a bit of comms, mostly sort of social media activity around. So that is a whistle-stop tour of what we did earlier in Q1 this year. So I believe the recommendations for the report are to comment and consider. So thank you very much for letting me babble on for a few minutes, but I'll open it up for a comment. Thank you very much.
Okay, thank you very much, Paul. I like this report because it lets us just see the visibility of the partnership and the reach as well that we seem to be having, so that's great. Okay, I'll open up. Any comment or questions for Paul? No. Okay, Paul, that's a good thing. Thank you very much for your paper today. Excuse me. And that then takes us on to item 13, which is the IIB governance report. I'm going to pass over to David for this report.
Yeah, thank you very much, Chair. As you'll see, this governance report is a bit of a blockbuster because we have 10 recommendations in it. And that's the culmination of a lot of the domestic work that I've been doing around governance arrangements since I came into post. And I've been working very closely with our senior service manager, Suzanne. And we've also had a bit of a turnover in our membership. So I'm going to go through the recommendations and just give a little bit of overview of the body of the report. So you look at recommendation 2.1, the appointments of Councillor Fiona Colley, Councillor Stacey Devine and Councillor Anne Hannah as voting members by Falkirk Council, and they were appointed at the Council statutory meeting on the 25th of May. Fiona Colley is also joining us again as Vice Chair of the Board. Now, Frank can't join us today, so we have Morvan attending in his place, but we're asking the Board to agree to appoint Frank on a temporary basis until a recruitment process identifies a permanent carer rep. We're also asking the Board to agree to reappoint Roger Ridley as the Falkirk staff representative and to agree to appoint Helen Welsh as the Falkirk Council staff representative substitute, and Helen is joining us today shadowing Roger. A couple of key things that the Board need to do today is we need to appoint a Falkirk Council voting member to the Clinical and Care Governance Committee, and to agree to appoint this member as chair of the committee. And we're also looking to appoint a Falkirk Council voting member to the Audit Committee and also appoint him as Vice Chair of the committee. As you'll see attached to Appendix 1, we're also asking the Board to agree the revised Code of Conduct and note that upon the Board's approval after this meeting, it will be submitted to the Scottish Government for ministerial approval and to agree the proposed meeting arrangements for 2022. I don't really need to go into too much detail about the membership, other than also just to note as well that following Angela Wallace leaving NHS Forth Valley, Gillian Morton's been appointed as Interim Director of Nursing, and the recruitment process for a permanent appointment is still ongoing. And I know Gillian was able to join us for a short while this morning. I'm just going to move on to the Code of Conduct. So the Code of Conduct has been revised. The Scottish Government had released been adapted from the Model Code of Conduct, which was issued on the 7th of December 2021. And there's some key substantive changes to the Model Code, and they're as follows. There's a general rewrite of the code to the first person, adopting plain English wherever possible, a greater emphasis on addressing discrimination and unacceptable behaviour, stronger rules around accepting gifts. There's been a substantial rewrite of Section 5, establishing 3 clear distinctive stages to determine a declaration of interest, connection, interest, participation, and making clear the rules around access and lobbying. We're also asked to note that we're going to have a IGIB development session on the 1st of July. So we're going to include a more detailed briefing about the revised code, and there'll also be an opportunity to look at the register of interest then as well. In terms of the meeting arrangements, some officers had a chance to do a little bit of background and had a discussion about meeting arrangements going forward for the IGIB. And we're proposing for the remainder of the calendar year that the Board and its committees continue to meet virtually as we have done, but to move platforms to Cisco WebEx so that we can live stream our meetings on YouTube rather than publish a recording of the meeting after the meeting. It just gives the public access in real time. Initial canvassing of members is going to take place in due course after this meeting, and the Board development session, which I mentioned, will be taking place on the 1st of July, will allow us to just talk about through the meeting arrangements in more details. And we're also proposing that any Board development sessions thereafter, that we test out a hybrid model, we pilot it to give members a good feel for how it works and just to get a sense of how this would work for the Board. So yeah, in terms of conclusions, the report summarises a range of matters to the IGIB and provides assurance that the necessary work is being done. Where further consideration is required by the Board, reports will be brought to future meetings. And I'll take any questions before passing on to the Chair.
Okay, thank you. Do we need to agree 2.6 and 2.7? Okay. I can see no hands, no questions. So, do you want me to go through each one of these again, or just the ones? Yeah, just 2.6 and 2.7. Okay then, so in terms of the recommendation for 2.6, we want to appoint a Falkirk Council voting member to the Clinical and Care Governance Committee and agree to appoint this member as chair of the committee. So how do we want to do this? Fiona?
Yes, I'm happy to nominate Anne Hannah for that role.
And is Councillor Hannah willing to accept said role? Do you mean
Yes.
You are. Okay, do we have someone who's willing to second this motion? Councillor Devine. Thank you very much. I presume you're putting your hand up to second this. Yes, thank you very much. Okay, 2.7, to appoint a voting member from Falkirk Council to the Audit Committee and agree to appoint the member as a vice chair of the committee. And we have Councillor Hannah.
I'd like to propose Councillor Colley.
Thank you very much. And do we have someone who's willing to second that? Councillor Devine, thank you very much. Is that everything? I think from what I can see, I've got no more spaces. Yes, okay, thank you very much, colleagues. That was well done and well executed. Did very easy for me, so thank you. Okay, are we happy then? I think in terms of Dave has been, Dave, I'll give you some name, David, and has been, he's gone through each one of these, so I will not go through them again. And unless there are any questions, I would propose we just move on to the next item. Fantastic. Thank you very much, David. And the next item is 14, which is approved minutes of meetings. And David, I have your name again on as well.
Okay. So these are just the approved minutes of meetings. There's only one thing that I would like to draw the board's attention to, and that is to also include the minute of the strategic planning group from the 12th of February 2021. And the reason for this inclusion is that an audit has thrown this up as something that was mistakenly not included.
That's absolutely fine, thanks. Any questions, any comments? No. Okay, thanks very much, David. Okay, thank you for your time today, colleagues, and welcome to our new members. As I've said, I hope to see you at the next meeting, which will be on the 2nd of September, I believe. Usual time 9:30. So we won't see you before then. I certainly will see you all then. So thanks very much for your time today, and I hope you all have a lovely weekend. Bye.